Welcome to OncoPharm. I'm your host, John Bizarro. I'm a professor of pharmacy practice here at our supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy, here on the eve of All Hallows Eve. A spooky time of year. It's a time of year to watch scary movies, and if you watch scary movies, you will notice a trend, a trope, a cliche in all of these movies is that the bad person, the villain, the monster, never dies. Always comes back. And so today, of course, we're talking about Belantamab Mafodotin. Not that it's a bad guy or a monster, but it was a drug that was dead and now has come back. So brief history of Belantamab Mafodotin, an antibody drug conjugate targeting BCMA, B-cell maturation antigen, which is on mature B cells and plasma cells. Mafodotin, a microtubule poison that's attached to it. So this drug was approved in 2020 based on an accelerated approval in the relapsed refractory multiple myeloma setting based on activity, based on response rate. There was then the DREAM3 study, which we'll talk about a little bit, which was negative, that read out the end of 2022. In February 2023, the manufacturer voluntarily withdrew the drug, and now, October of this year, it is back on the market. So, let's look at the DREAM3 study, which was the study that got Belantamab Mafodotin that had been on the market based on just response rate removed. And this was a study of Belantamab Mafodotin monotherapy, key thing, that was monotherapy, and these were patients in the third line or beyond setting, and it was compared to pomalidomide and dexamethasone. I probably made fun of this at the time. If you can't beat Pomdex, you're probably not a good drug. The dosing of Belantamab Mafodotin was the standard dose, 2.5 mg per kg every 21 days. Now, what was curious about this, there was no overall survival difference. If you look at the Kaplan-Meier curves, OS of Belantamab Mafodotin compared to Pomdex was exactly the same. If you look at the PFS curves, kind of violated the proportionality rules of the Cox proportional hazard model ratio, whatever it is. The median PFS was 11.2 months, favoring Belantamab Mafodotin compared to 7 months with Pomdex, but the hazard ratio point estimate was 1.03 on the other side of 1, on the bad side of 1. So if you look at these Kaplan-Meier curves, you see initially the Belantamab Mafodotin folks are progressing or dying at a faster rate than the Pomdex group. But in the long run, the curves cross and Belantamab Mafodotin seems to have some better benefit long run. Now, that may have something to do with those who could tolerate it did well, and those who couldn't tolerate it progressed very quickly and could not get anything. Perhaps due to toxicity, they had to go many months without treatment, which can happen with a drug that many people have called not the brand name Blenrep, but Blindrep, because of the ocular toxicities associated with this, which we will come back to. So now let's come to DREAM7. And by the way, DREAM is spelled with 2 M's because it's a multiple myeloma study. So DREAM7, which was actually conducted, they enrolled patients in the same 2020 to 2021 timeframe that DREAM3 did. And this is not single-agent Belantamab Mafodotin. This is combination with bortezomib and dexamethasone compared to Daratumumab in combination with bortezomib and dexamethasone. Now, the Velcade or bortezomib dosing here is 1.3 milligrams per meter squared, days 1, 4, 8, 11. In both arms, dex is I think it was 20 milligrams on days 1 and 2, 8, 9, so basically 40 milligrams weekly. And the Velcade and Dex went for 8 cycles, and then you went to monotherapy of either Belantamab Mafodotin or Daratumumab. I will point out that the Dara dosing here is different than what it is in many other indications, but is similar. Basically, these patients were getting 16 mg per kg, that standard dose of Daratumumab. They got it weekly for 3 cycles. So weekly for 9 weeks, because these were every 3 cycles. And then every 3 weeks for cycles 4 to 8, and then monthly thereafter. Probably the most common Dara dosing is weekly for 8 weeks or 2 28-day cycles. Then every 2 weeks for a while, and then monthly. So maybe they got a little bit less Daratumumab. However, these were folks, by and large, who had not received any Daratumumab. The median age was 65 in DREAM7, which is kind of what we'd think. And half these patients were getting this in the second-line setting, so had 1 prior line of treatment, and basically half were on the second line or more line of therapy. Now, that's notable. So this DREAM7, the pivotal study that got Belantamab Mafodotin, FDA approved again in combination with bortezomib and dex, does not match the approval. So the approval is only in patients who have received at least 2 prior lines of treatment, okay? So if you look at the total results here, and these were published in the New England Journal of Medicine in 2024, these patients had a time from relapse of more than 12 months, 80% of the time. So these were somewhat indolent patients. 86% had prior bortezomib, 80% had prior IMiD, only 2% had prior Dara. And if you look at our PFS, the 18-month PFS was 69%, favoring Belantamab Mafodotin versus 43%. That's a hazard ratio of 0.41. That is in the entire patient population, including those on second-line treatment and those on third-line and beyond treatment. So if we look on the efficacy data set of what the FDA approval is, these are only in folks who had 2 prior lines of treatment. So now instead of having about 490 people in this study, we have about 110 in each arm. The PFS hazard ratio is more impressive in the folks that are more heavily pretreated. So 2 prior lines of treatment. That point estimate is 0.31 in the entire population. Just for reference, it was 0.41. And we actually do have an overall survival benefit in this patient population with a hazard ratio of 0.49, 95%, confidence interval 0.32 to 0.76, which a p-value that's like 0.0002. There are 3 zeros, then a 2. To be statistically significant, it had to be 2 zeros and then a 1, 2. So it was a significant improvement in overall survival, albeit with only a couple hundred patients, only 100 patients on this combination of Belantamab Mafodotin in combination with bortezomib and dexamethasone. And this updated OS is published in Lancet Oncology in 2025, so this year. So we have a drug that looked like it worked based on response rate, looked like it didn't work as single agent compared to Pomdex, and looks like it has some benefit in combination with bortezomib and dexamethasone. And again, all of these patients have received bortezomib and dexamethasone in the past. Well, 86% had prior bortezomib. So, and this is something we do. We recycle these drugs a lot in multiple myeloma. And so if you look at, say, somebody like Vincent Rajkumar, who is one of the most respected, not just multiple myeloma physicians, oncologists, and experts, but also as a patient advocate, has said, hey, this is a good approval. This is a good drug to have. We know it's got some toxicity. But it's a BCMA targeted drug, and we know BCMA is a really good target for myeloma. We have CAR-T that targets that. We have bispecific monoclonal antibodies that target BCMA. But not every community center has access to, or has familiarity, comfort, or the resources to manage the cytokine release syndrome and ICANS that can happen. And we think the more disease burden you have, the greater the risk of CRS and ICANS. So maybe you could see some folks that need some treatment right away and aren't able to travel to a tertiary referral center or somewhere where they could give bispecifics, say in a very rural area. Maybe they could do this for a few cycles, reduce the disease burden to the point that they're able to go on and do your bispecific or even CAR-T, which has really some promising data. So those are some of the the pros of this. The concerns are we still have these ocular toxicities, and what I didn't mention here is there's also a study, DREAM8. And in DREAM8, they do a different dosing of Belantamab Mafodotin. They do 2.5 mg per kg for the first dose, and then 1.9 mg per kg every 4 weeks, compared to 2.5 mg per kg every 3 weeks. And the dose reduction for Belantamab Mafodotin is a decrease to 1.9 mg per kg every 3 weeks, or you decrease the frequency even more, like, basically wait until you're back to grade 1 before you give the drug again. So we maybe don't know the dosing, and this is not necessarily uncommon. I've talked about this quite a bit. Is the first time a drug is FDA approved, we don't always know what the best dose is. The question is, especially if, I think it's something like 86% of people on this study, I have it written down somewhere, but I was writing it with my bad pen, and my bad pen, I can't, it doesn't show up as well, but it's above 80% of people in DREAM7 who had to stop the drug, either a dose interruption or dose reduction because of toxicity. That sort of is screaming safety flag. This is not the best dose for these people. If we're having to reduce the dose in pretty much everyone. The question then is, starting everyone on a lower dose, which probably will happen in practice, is that still have benefit? And that becomes a ripe real-world study for someone to do who's going to use a lot of this drug, Belantamab Mafodotin. So I think that the dosing probably will evolve in the real world. For now, what I would recommend to my doctors is do what the label says with regards to that. Now, there is a REMS program associated with this. the website for the REMS program is not available. It goes live on November 12th, 2025. Maybe when you hear this, it's live if you kind of batch these and listen to several of them at once. So we'll see. The PI right now says to do preservative-free artificial tears at least 4 times a day, people on this drug. If you look at the DREAM7 protocol, which you can see on the NEJM website, they said 4 to 8 times a day artificial tears. 8 times a day is a lot. It's like every time you go to the bathroom or take a drink of water, do some teardrops in both eyes. The protocol in DREAM7 also advocated for a cooling eye mask for at least an hour or up to 4 hours as long as the patient could tolerate. Based on the PK data here for Belantamab Mafodotin, we do know that the peak concentration of this drug is very much at the end of the infusion. And we don't think of monoclonal antibodies as drugs where you worry about the peak concentration and peak associated toxicities, but perhaps this is, and this is a 30-minute infusion. So if you can do the ice for an eye, do an ice mask or a cold compress on the eyes. I don't see it's going to cause any harm. It's a little odd that was in the protocol for DREAM7 and didn't make it to the label. It makes me wonder if they have some data where they know that doesn't work. If you read what some of the ophthalmologists have written about this, it has been hypothesized that this drug gets absorbed into the epithelial of like your eyelids, and then you get some exposure to the cornea, which is the top layer of the eye, and you can get this punctate keratopathy pretty commonly, where you have these little studded dots of damage or inflammation to the cornea, and you just kind of have to let it go until the cornea replaces itself, which can take weeks, which is why it seems to be the best approach for toxicity is time, not dose reduction, so to speak. And of course, these patients need to see an ophthalmologist before their first dose and then before every subsequent dose, including a slit lamp examination. So you need to become friends if you aren't already with your ophthalmologist in the area, and have good warm handoffs of why they're coming there for evaluation for this drug, and so the ophthalmologists are familiar with what they're looking for. So Belantamab Mafodotin, Blenrep, back on the market. REMS website's going live in about 2 weeks, which means it'll probably be available for purchase commercially here in the States thereafter. So I think that if you're looking for research projects, I think real-world dosing of this, and does that match what was done? Do we think the same effectiveness in the real world? Tough to demonstrate. And then what other tricks is cooling eye mask? Does that make a difference in the toxicity? We know that these drugs have pretty long half-lives as monoclonal antibodies, so maybe just decreasing how much initially gets there during the peak can be helpful in minimizing maybe the severity of the toxicity, if not even the incidence of the keratopathy. So, and again, a lot of people, their visual acuity went down because of that, and that's that's all over the PI and the studies as well. So that's Belantamab Mafodotin, our little tale from the crypt for this week. Thank you so much for listening. You can follow me on the app formerly known as Twitter at PharmDatenib, and the podcast on most social media platforms at OncoPharm or OncoPharmPod. And until I talk to you again, remember, doses matter.